Many patients with relapsed ovarian cancer receive several lines of treatment following occurrence. Deciding which treatment to use, as well as the timing and sequence of therapy, is complex. So, Werner, I want to ask you, when you see a patient with a rising CA-125, do you begin treatment immediately or wait for symptoms to appear?
And I think this is actually probably the hardest conversation that we have in GYN oncology, because I think everyone at this table recognizes that when that CA-125 goes up, in all probability represents a recurrence. And the question always is, do you treat now or do you treat later? And so the first thing is I always ask the patients are whether or not they're symptomatic or not. Are they having pain? Are they having other issues related to their ovarian cancer? And I don't think we've ever demonstrated that treating right at the time of their quote-unquote chemical recurrence, assuming they don't have any relevant CT findings or PET CT findings, treating now or later actually portends a difference in their outcome and their survival. And so, for me, it's about, really trying to understand what their goals of therapy are. And so I do have an honest conversation with them that I think it's completely reasonable for them to delay their therapy until they become more symptomatic. It's a discussion that many patients don't like hearing, and it takes a lot of time explaining that perspective. But to answer your question, I would like for them to have symptoms, but in all honesty, probably at least 2/3 of my patients we do wind up treating. But I make them very aware that we're basically treating a number in essence. So,
this is a very important question and complex. So, other comments?
Well, there is a randomized trial that addresses this. It's a British trial where they randomized patients, where they had followed patients who were in a CR after initial treatment, and at the point where the CA-125 level reached twice normal, they randomized the patient to either get their information or not get their information. In other words, you couldn't do this trial in the U.S. There was absolutely no difference in survival between the group that got their information and got immediate treatment and the group that did not get treatment until there was other evidence of disease, such as either symptoms or scan findings that showed that they had definitely had a recurrence. Not only that, but the group that got their information and got treated earlier actually had a poorer quality of life. They had a deterioration of quality of life on an average of 3 months earlier than the group that got the delayed treatment. So that study not only says that we shouldn't be treating a rising CA-125, it also says that we actually harm patients in terms of quality of life when we treat them early.
So what do you actually do, though?
I don't treat rising CA-125s, but then I haven't treated rising CA-125s since the mid-90s. We usually set aside an hour to an hour and a half for the patient with a rising CA-125 to sit down and discuss the issue thoroughly with them, answer all questions they have. And what we found is that once you do that with the patient, and they understand that you're going to be watching this situation closely, that virtually every patient is agreeable to that particular approach.
And time is of the essence in any education with patients. And in Mississippi, I guess it's not an issue.
Well, we don't have the same patients that they have on the East Coast, I agree, okay?
Yeah, and obviously this is a very complicated issue. And the fact is that patients often know their laboratory result before the doctor does.
That's right.
They'll call the lab, they'll call the nurse. They know exactly the time that the lab test will be available, and that's the day they call. Because obviously, we've now talked about the relapse setting. We have the exact opposite. The patient has a high CA-125. We treat them at the beginning. The CA-125 goes down. It's a very good news, and we all use it appropriately. It's not an inappropriate, but it's hard to then turn around to some patient and say, and by the way, now we've had all the good news we're going to get on this. It's normal CA-125, you're doing fine. We're going to stop following you. It's difficult. And so really, Mike, that really leads to the question to you. What is the value of following the CA-125? We've heard about this study, but okay, is there a value in doing this?
Well, I think it's helpful quickly to broaden that question in that, because there's some confusion out in the community also that CA-125 has been analyzed in every aspect of the disease. We should put out there that screening patients with CA-125, the general population, for the early detection of ovarian cancer is absolutely worthless, and that should not be done. But we're talking about following CA-125s during treatment and then afterwards for detection of disease recurrence. I think it's an interesting adjunct while we're treating patients. The dropping CA-125 is good to know. It doesn't really change management. We really rely on scans. And then during the recurrence, we've already discussed it, which is that a wonderful prospective randomized study showed that it's not a lot of value, and as Tate pointed out, those patients that were told got 18 cycles more of chemotherapy. So I think the value and what we try to do is use it as an adjunct to tell you when to get a scan.
Exactly.
And the reason you're doing that is the last thing you want to have happen when you're treating a patient with recurrent ovarian cancer is for them to develop symptoms. You want to catch it before that and begin to map out a therapeutic regimen. So that's usually what we do.
And is that, in your opinion, like Tate, successful? Not patients have a rising CA-125 and no symptoms? Or are you able to you put them on tamoxifen? I mean,
yeah. So it is all tailored to the anxiety of the patient. So there are some patients who say, you know, I've seen enough of you, Dr. Birrer, so I want to go about my business and I'll be back. And they're comfortable just following a CA-125. But there are others that have an anxiety level where you either have to intervene with something you don't think is particularly toxic, like tamoxifen, or there are those occasional patients you have to come in a little more aggressively because just insisting on it. And I've actually, on occasion, been using bevacizumab for this as a single agent.
And in certain situations, you get false positive information because you'll see early rises in CA-125 and subsequent decline and sinusoidal patterns and all kinds of nonspecific effects that don't necessarily equate to true disease status in a patient.
In fact, that last point is very important. I think it's, if you're going to monitor CA-125, and I think you should for the same reason that Mike stated, that it cuts down on the number of scans you're getting and other things. The criteria for determining whether a single value is accurate or not is whether it persists over time. In other words, a steady rise for 3 successive values should really be the criterion with one of those values above 100 before you conclude that that definitely points toward a recurrence.